Now we will focus on endocrine disorders that are associated with some of the hormones we have covered in Chapter 17. First, we will begin with growth hormone. Now, one of the conditions related to growth hormone is pituitary dwarfism. Pituitary dwarfism. It is caused by the hyposecretion of growth hormone during the growth years, basically during childhood. It causes a slow growth and the premature closing of the epiphyseal growth plate before normal height is achieved. The opposite of this condition is what we call pituitary gigantism. Now, this is due to the hypersecretion of growth hormone during the growth years. It basically occurs before the fusion of the epiphyseal growth plate, thereby causing an abnormal increase in the length of the long bones. Now, a similar condition is what we call acromegaly. Now, acromegaly is also due to the hypersecretion of growth hormone, but during the adult years. Okay, it occurs after the epiphyseal growth plates have closed. It leads to the enlargement of bones within the face, the hands, and the feet. So basically, we're not seeing an abnormal lengthening of the bones. No, rather, we are seeing a thickening of the bones within the face, the hands, and the feet. Next, we will focus on ADH, antidiuretic hormone. The hyposecretion of this hormone will lead to diabetes insipidus. Now, this condition is characterized by polyuria, which is excessive urination, which leads to dehydration, which then leads to excessive thirst. So let's review a little bit. ADH usually promotes the reabsorption of water from the kidneys back into the blood. But a low amount of ADH than normal will lead to what? Excessive what? Water loss, right? So the body will not retain water. It will lose a lot of its blood volume. Okay, so this is why we have the polyuria. And of course, with this comes the dehydration, and with that comes excessive thirst. The opposite of this condition is known as the syndrome of inappropriate ADH secretion. Now, this is due to the hyper secretion of ADH. So you have too much ADH in the blood, which will lead to what? An increased water retention, hence the increased body weight. Next, we're going to talk about the thyroid hormones. I am referring to T3, known as triiodothyronine, okay, and T4, known as thyroxine. So again, T3 is triiodothyronine and T4 is thyroxine. Okay. Now, a hyposecretion of these hormones will lead to the condition hypothyroidism. Hypothyroidism. Hypothyroidism is commonly caused by an iodine deficiency or an autoimmune condition. So remember, iodine is necessary. It is required to produce T3 and T4. Okay? And here is another problem. If we have an autoimmune response against the TSH receptors on the thyroid gland, then TSH will not be able to stimulate the thyroid gland to produce T3 and T4. Hence, hypothyroidism. Okay? Now, individuals that have this condition, their blood tests will show low levels of T3 and T4 and elevated levels of TSH. Right? Now, there are two forms of this condition. There is a childhood form and there is a adult form of it. So let's do the first one. The childhood one is called cretinism. Okay? It's also known as infantile hypothyroidism. Now, cretinism is also called congenital hypothyroidism. What is it usually due to? It is due to congenital iodine deficiency. Okay? And sometimes, if a newborn has an iodine deficiency, it is most likely due to the mother having iodine deficiency when she was pregnant with with the fetus. So do keep this in mind. Cretinism, the common cause for cretinism is what? Iodine deficiency. And usually these newborns will have stunted physical growth, mental retardation, basically developmental delay. Now, what about the adult form of hypothyroidism? We call this myxedema. So the hyposecretion of T3 and T4 occurs during adulthood, and this causes edema in the extremities, the abdominal region. Basically, we end up with swelling all over your upper and lower limbs. Okay? These patients usually experience slow heart rate, low body temperature, and definitely weight gain. Now, the opposite of hypothyroidism is hyperthyroidism. Patients with this condition, their blood test will usually show an elevated level of T3 and T4, but very low levels of TSH, hence hyperthyroidism. So what you're seeing here is a hypersecretion of T3 and T4. But why? Okay, that leads me to this disease, this one, Graves' disease. Now, Graves' disease is an autoimmune condition. This condition basically involves the overgrowth of the thyroid gland and the hypersecretion of T3 and T4. Basically, the antibodies, which are part of the immune system, they overstimulate the TSH receptors on the thyroid gland and basically cause the thyroid gland to abnormally grow and produce T3 and T4. So what are some of the signs and symptoms we see in these patients? Definitely a high metabolic rate and body temperature. Now, some of these patients will have a periorbital edema of the eyes. And then some of them will exhibit this sign known as exophthalmos. It's basically when they have this bulging eye appearance. Okay, so they come in with bulging eyeballs. Seriously, yeah. Once we see that sign, we definitely know this patient most likely has hyperthyroidism. Now, these patients will also experience weight loss. Okay. Now, I want to talk about goiter since we're talking about, hypothyroidism and hyperthyroidism, and this has to do with the thyroid gland. Let's talk about goiter. Now, what is goiter? Goiter is basically an abnormally enlarged thyroid gland. That's all it is. So the thyroid gland is just abnormally large. And this is normally caused by iodine deficiency. Okay? However, it can be associated with hypothyroidism and hyperthyroidism. But you cannot use just the goiter to diagnose a patient with hypothyroidism or hyperthyroidism. Basically, what I'm trying to say is a goiter can be seen in a patient that has hypothyroidism or a patient that has hyperthyroidism. Okay? I just want you to just remember that a goiter is basically an abnormally enlarged thyroid gland. Now we're going to focus on the adrenocortical hormones. I am mainly referring to cortisol and aldosterone. The first condition I want to talk about is Addison's disease. Addison's disease is due to the hyposecretion of cortisol, primarily cortisol, but sometimes it also includes the hyposecretion of aldosterone. So in some patients that have Addison's disease, their adrenal glands are producing very, very low amounts of cortisol and aldosterone. But in others, their adrenal glands are producing very low amounts of just cortisol. Okay, so remember that this condition is due to the hyposecretion of cortisol and sometimes aldosterone. Now, what causes this problem? Why do we have a hyposecretion? Well, it is mainly due to an autoimmune response. So again, those antibodies that are part of your immune system, what they do is they will attack the adrenal cortex, basically to destroy it. If you destroy the adrenal cortex, you will definitely end up with what? A very, very reduced production of cortisol and aldosterone. Okay? Sometimes it can be caused by other diseases such as tuberculosis. So patients that have this condition, what are some of the signs and symptoms that they will experience? Well, if you're talking about the hyposecretion of cortisol, I want you to think of the normal effect that cortisol has on the body. Remember, cortisol is a stress hormone. During stressful condition, it helps the body to do what? Mobilize its energy reserves. It also helps the body to basically deal with inflammatory responses. So it's an anti-inflammatory hormone. But if the body is making very little amount of cortisol, what do we end up with? Well, you can end up with hypoglycemia. The body's ability to deal with stress decreases. The body's ability to mobilize its energy reserve goes down. The body's ability to maintain normal blood glucose, that decreases also. Are you following? So basically, these patients will be highly fatigued. Okay, so that is if you're talking about just cortisol. But what about patients that have, a decreased secretion of cortisol and aldosterone? Well, let's talk about the aldosterone aspect. Well, if you have a low amount of aldosterone being released, what do you end up with? Well, you can end up with a low, blood level of sodium ions. You can also end up with a low blood volume, right? And high blood potassium ion levels. Okay? And you can definitely end up with what? Polyuria. All right, so make sure that you know the signs and symptoms of each of these conditions, okay? Next, we're going to talk about a condition that is due to the hypersecretion of cortisol. This condition is known as Cushing's disease, okay? Like I said, Cushing's disease is due to the hypersecretion of cortisol, by the adrenal glands. Now, the main problem here What causes the hyper secretion of cortisol is actually the hypersecretion of ACTH by the pituitary glands. So if there is a pituitary tumor, it can cause the anterior pituitary gland to produce excessive amounts of ACTH, which can then lead to what? The hypersecretion of cortisol by the adrenal glands. Okay? Now, hypersecretion of cortisol can also be due to the overuse of corticosteroid drugs for an extended period of time. So, what am I saying? I am talking about a condition called Cushing's syndrome. So, if your blood has a high level of cortisol due to you using corticosteroid drugs for a long period of time, you will end up with this condition called Cushing's syndrome. But if your blood has a high level of cortisol due to a pituitary gland tumor, then you have the condition known as Cushing's disease. Okay? And in both conditions, these patients will experience weight gain, fatty deposits around their upper back, their face, around their belly region, and they will also experience hyperglycemia, hypertension, and also hyperpigmentation of the skin. Finally, we are going to focus on insulin. And I want to focus on diabetes. Okay, diabetes mellitus. So, diabetes mellitus, what is this characterized by? Well, high blood glucose levels, right, which we call hyperglycemia. And this usually leads to polyuria, polydipsia, and polyphagia. Okay, polyuria is basically excessive urination. Well, think about it. Normally, insulin enables the cells of the body to do what? Absorb glucose from the blood, and then the cells can now use this glucose for energy. But when we don't have insulin or enough of insulin, the cells will not be able to do what? Absorb glucose, for energy. So what happens when we have excessive amount of glucose in the blood? Well, your kidneys, under normal circumstance, they filter the glucose and then reabsorb it back into the blood. But when we have a large amount, right? Excessive production, of glucose in the blood. Well, guess what? The kidneys will not be able to reabsorb everything back into the blood. So some of that, glucose will end up in the urine. Okay? Now, with glucose staying in the urine comes water. So water will be moved from the blood into the kidneys and eliminated with those, the glucose molecules in the kidneys. So now what do you have? You have what? Polyuria, excessive urination. And it's not just any kind of urine. You're basically going to be eliminating some sweet urine filled with glucose. Okay? Now, with the loss of water comes dehydration. All right? And this dehydration will lead to excessive thirst, which we refer to as polydipsia. Now, let's talk about your cells. If the cells, cannot gain access to glucose, they will begin to starve. They become glucose deficient. Are you following? And that will basically trigger your body to want to eat more. So you begin to experience persistent hunger. Okay? So this leads to what? Polyphagia, which is basically excessive eating. You're just eating and eating, and the reason is because the cells are unable to access the glucose in the blood. Are you following? So this is what we see with diabetes. So now let's talk about the two types of diabetes. Type 1. Type 1 is actually an autoimmune disease. It is when your antibodies attack the beta cells of the pancreas. And once they destroy those beta cells, well, guess what? Insulin will no longer be produced. So in type 1 diabetes, the pancreas cannot produce insulin because the beta cells are destroyed. So how do we treat this? Patients that have this condition must receive exogenous insulin, basically synthetic insulin, through injections or infusions. Okay? And I want to talk about another, characteristics of type 1 diabetes, something we call ketoacidosis. You should be familiar with that term, but I just want to relate it real quick for you, okay? So the body cells in a diabetic state, the body cells are glucose deficient. They need energy. They usually use glucose to make, energy, ATP. But when glucose is not available, what can they use? Fat. So the liver then will begin the process of breaking down fat. But you do remember a byproduct of fat metabolism is the production of ketone bodies. And ketone bodies are notorious for making your blood acidic. Hence, the ketoacidosis we usually see in type 1 diabetes. Okay? Now, type 1 diabetes is very common in patients that are less than 40 years of age, okay? Especially children. All right? Now, what about type 2 diabetes? In type 2 diabetes, the beta cells are not really destroyed. So it's just that you're not producing enough insulin. Okay? The beta cells are working, but for some reason, they're not producing enough. Or sometimes the beta cells are producing enough insulin, but guess what? The cells are not responding to insulin. So they're not getting the message that they should absorb glucose, right? So they're not getting that message. So I'm referring to insulin resistance. So with type 2 diabetes, what do we have? We have very little amount of insulin being produced, or the cells are experiencing some type of insulin resistance. Okay? And what are some of the risk factors for type 2 diabetes? I am covering this because type 2 diabetes is very common. 92% of our diabetic patients usually have type 2 diabetes. Only about 8%, have type 1 diabetes. Okay, so type 2 is very common, so this is why I want to cover the risk factors. And the risk factors are poor diet. Having a poor diet, lack of exercise, obesity. So these are the common risk factors. However, though, we found that type 2 diabetes can be managed, right, with what? A controlled diet, exercise, and weight loss. And sometimes patients that have type 2 diabetes, they might require some insulin injections. Okay, sometimes, not every time. All right, so these are the two differences, the main differences I want you to know between type 1 and type 2 diabetes. Finally, I want to talk about hyperinsulinism. With hyperinsulinism, we will see that the patients usually have a very low blood glucose level. Okay, and this is dangerous because it can lead to a state of coma. So now that we have finished chapter 17, I do want to encourage you to study each hormone that we have covered. Make sure that you can generate a chart like this one. Okay, start off with the hormone. Determine the endocrine gland that produces the hormone. Determine the stimulating hormone that enables that, that causes that endocrine gland to produce the hormone. Know the gland that produces the stimulating hormone. Then go back and talk about the region of the nervous system that produces the regulatory hormone that controls the pituitary gland. So do this for all of the hormones, okay? And then include the effects of that hormone on the body. So if you can make a simple chart like this for all the hormones, I think you'll be well prepared for the exam.